So, afternoon, everyone, and thank you to all of you who are in this room. Um, tells us about our choice of topics and the fact that you all find the need to share ideas more on CGM. So, many of us in the room here are extremely passionate about CGM, and we heard three wonderful conversations right from, why it should be used by kind of everyone, also then understanding AGP, and then the conversation by Dr. Xavier, who did in the end touch upon probably type 2 diabetes as well. And my talk is largely going to be type 2 because I'm doing very specific conversation on OHA adjustment. So in many markets across the world, it continues to be used predominantly in type 1. And then gradually it has moved, but many question its use in type 2. Frankly, it doesn't make any sense to me. Every time over the last several years, I've had critics questioning my propagation of use of CGM in every individual with diabetes, because how wrong can monitoring be? Right? And this question can come up in countries where they have to justify to insurance and the state who pays for their healthcare. Here, unfortunately, all of us are paying for our own healthcare. So how can you be wrong if you want to monitor your sugars or the movement across? So which is where today I'm speaking on largely the OHA adjustment. Do we have a pointer here? AV team? Pointer? कहाँ है? अच्छा AC पे? हाँ, इधर. Thank you. Okay, so let's start with the guidelines. With the things have also evolved. You look at the 2025 standards of care from the ADA. It calls about consider using real-time CGM, and where it is the intermittent scan CGM in adults with diabetes treated with glucose-lowering medications. That's not only insulin. It includes your OHAs as well. In fact, glucose lowering other than insulin to achieve and maintain individualized glycemic goals. The choice of device should be based on individual circumstances, preference, needs, and in our aspect, availability and cost. So availability is an important issue. We released the RSSDI expert consensus last year, and we spoke on the similar lines that recommended frequency we spoke about of assessing CGM is twice a year for patients with a TIR of more than 90%. Now, these kind of recommendations you'll see only from India and self-pay markets, because the West probably doesn't have to worry about frequency. They'll talk about what is ideal, and ideal is that patients use it continuously. But when there are aspects of cutting down or using it more prudently and economizing, then we are talking about these recommendations that use it at least twice. Use of clinical judgment or more frequent CGM in patients who are at risk of hypoglycemia. Frequency can be minimized for patients with desirable TIR with minimal TBR. And which gets me to a question to all of you. What do you feel is the most important use of CGMs? Any of you? Hypoglycemia, and I get my answer there. That's the most important aspect. It's not about how much TAR you're having, that's important, but the most important critical part of using CGMs is preventing TBR or hypoglycemia or picking it up earlier. So let me move to these case studies, which I have very simple case studies from the clinic itself. We start with the first case. 66-year-old male, 13-year history of diabetes, hypertension, some blister pressures and some hematoma and pressure blisters on the toes, scheduled for cataract surgery. Now, this individual was extremely keen that he gets into very, very tight control. For some reason, he was at 7.1, which many of us would be fine, go ahead with cataract surgery. So no, somebody in my family had a complication. I want to be at 6.5 before I go ahead for the surgery. What was the patient on? On metformin 850 milligram. Again, this is what the patient was on from before, so don't question me why the patient was on metformin, and this is not about that aspect. So patient was on metformin single tablet. Said fine. What do we do when let's say somebody is at 7.1, 7.2, 7.3 on metformin alone without any other major complications? What kind of combination would we use to get to 6.5 without hypoglycemia? DPP4 and metformin combination. Thank you. Makes my job easier. So I think like y'all, and I learned from y'all. So I said, okay, we'll move to metformin and a DPP4. So we did a Vilda-Met 50-500 twice a day. Right? Many of you would do the same thing. Excellent. Do these combinations cause hypoglycemia? Okay. So that's where we are mistaken. If we think Metformin doesn't cause hypoglycemia. Think again. Metformin also, in some circumstances, causes hypoglycemia, and so do DPP-4 meds also. So let me not shock people here, right? Yes, they largely don't. They do not cause as much as sulfonylureas, but these drugs also can cause hypoglycemia or at least level 1 TBR. So this is where the patient starts using the real-time CGM, and of course, a lot of this is connected care now, right? What they are using, we are able to track at our clinics and see, and patient can send the message in. So the patient starts experiencing nocturnal hypoglycemia in the first few days of use. Well, many may question that it is just the first, second day. It could be overreading of hypoglycemia. Let's give it time. But how do you explain that to a patient who sees this on day one and then by next day and is complaining of symptoms, has dropped to 53s and 54s in the middle of the night? And he said, we changed this drug and I'm extremely uncomfortable and I've woken up in the night and I've seen this also. So patient is experiencing some amount of hypoglycemia on a DPP-4 metformin. So we said, so one suggestion is that, Manoj, you should have tried once a day. Well, so honestly, I did not know about the patient's overnight profile, and the fasting that I showed you, sir, was 126, which if I have to get him to a 6.5, I have to improve on the fasting sugar as well. So which is why I chose the right dose of twice a day. But having seen this, right, we switched back. So we said, hold on. Maybe by just using the CGM, the patient is going to be more focusing on his lifestyle and trying to improve that. So let's take a step back for now, and we go back to metformin. And also made me think that sometimes today, even before changing the drug, you may want to do a CGM, which should actually guide you to make your treatment decisions. Here, of course, we did it parallelly, and maybe we were wrong. So we said, okay, go back to metformin 850. You are satisfied, you're not worried, and we watch on the CGM what's happening. So the patient does that, right, and doesn't have any hypoglycemia, and is on single metformin. But over the next few days, we start picking up some peaks and patterns. And what do we pick up in the AGP? We pick up typically, there are some spikes, but the largest of them is at dinner. Right? Very often in Indian population, you will see that at breakfast and not dinner. In spite of we eating poor breakfast, the breakfast surges are predominantly more. But here, we saw it at dinner. Patient on metformin 850 in the morning, only dinner spike, had a kind of hypo with DPP-4 metformin. What do I offer this patient? AGI. Sir, I've been learning from you all throughout, so which is what I did. So we did an AGI, right? So that's what we did here. And we said, fine, let's put this patient on an A-carbose 50 milligram only with dinner so that we reduce this spike and we hopefully get this patient to a 6.7, 6.5, 6.8 so that he can get the cataract surgery done and move on. So that's what we did for this patient. We moved to the second case, 37-year-old male, diabetes since 5.5 years, presented for follow-up after 4 years. How many of us see such patients? Saw you in the beginning of the diagnosis, you started again some metformin. In those days, it was only metformin with lifestyle is what we did, right? And then patient was fine and now comes back after several years with an A1C of 10.4%, 245, 404, pressures fine, BMI on the higher side, right? What would we offer such a patient? 10.4 on metformin 500 BD. Sorry? Triple drug combination. Okay. What else? DPP-4 BD. So sulfonylurea, triple drug. Anybody wants to give insulin? Did you all attend the insulin school yesterday or today and raising the hands for insulin? Right. So yes. So there is no right and wrong answer. Honestly, you have the option. So you can choose based on the therapies. If somebody decides to use insulin here at a 10.4, you're never wrong. You're trying to overcome the glucotoxicity and help. But having said that, many of these patients, if they are largely asymptomatic and ready to change their lifestyle, may also respond to other drugs, which could be a sulfonylurea, which could be a DPP-4, which could be a triple drug combination with SGLT2 and so on. So patient on metformin, and we did somehow, we said, okay, we'll still have faith in DPP-4 metformin and start this, right? And again, of course, patient came after 4.5 years, was geared up for lifestyle change and, a whole course of sitting down with your educators and dietitians and so on. So, well, the insulin or DPP4s were not introduced immediately. DPP was introduced, in fact. And patient here also mentioned recent travel and give me time. I had indulged at a wedding and so on. So, doctor, I have not behaved myself. So, don't punish me with insulin or, don't increase my drugs so much. Just give me some time and I'll get down. Do we hear this very often from our patients? Right? So, and we are good doctors and we listen to our patients. So, he said, okay, we'll give you time. Right? So then we said, okay, we'll not get onto very high drugs, but let's monitor and see how you're responding. Maybe in 2 weeks' time, I may have to move to insulin or get on to another more efficacious drug. So we start doing the CGM, and CGM over the next 2 weeks, to our surprise, does show better glucose stability and gets into a 97% TIR with a 1% low. Follow-up after a month, patient has done well, lost 3.5 kgs with structured diet and exercise. CGM then starts showing some amount of nocturnal hypoglycemia, again on a DPP4 metformin, right? So patient's A1C also has come down from the 10 point something to 6.8. Now this is not really shocking, and I tend to do this more because I was part of a trans-Asia study called the Initial Study, where we did offer vildagliptin metformin to drug-naive patients right from the beginning. And we had a subset analysis that a lot of patients who were at about the 10.5% A1C average actually dropped their A1C by 3.5%. So my conviction built up many years back as a primary principal investigator for that study that DPP4 meds, of course, your Asian patients respond very well. So I said, fine, let's see this. But also we are now picking that because of the patient's effort, there may be some drops as well. And then this is the daily picture. So you're again picking up a lot of at least type 1, your level 1 TBRs, which is being picked up. Of course, patient is saying, no, I'm getting better diet, exercise, I have lost weight. What do you want to do with the medication? So fine. Not probably the best example, but this is what we all ended up doing, that you're going to use partial amount of DPP4. So you're doing a Vilda met in the morning and bringing down to only metformin in the night and seeing how the patient does. 2 months later, patient comes back, no hypoglycemia, you're seeing a 95% target in range, and patient is good on this drug, and we continue the same. So again, an example of using CGM just to guide you on the OHA use, which is my topic of conversation. Third case, type 2 diabetes, IHD, CKD. Real-time CGM regularly, patient used TIR of 80% approximately with no repeated hypoglycemia episodes. 7.8% is the HbA1c. This is about 2 years back, Jan 23. Patient is on 2 doses of premix insulin, uses repaglinide and voglibose. Why is the patient on repaglinide or voglibose? Because CKD, yes. So in our country, CKD, then repaglinide, voglibose becomes a combination of choice. Though, of course, the GFR is 46. So the metformin is still on, and the patient is on a Lina metformin combination along with repaglinide, voglibose, and the insulin. So this is, patient is using the CGM. This is what the CGM data we pick up. What do we see here? So we're seeing what? 89% in target, 10% above target, 1% hypoglycemia. We're seeing about 12 low glucose events, right? So, and you're also seeing, do you identify anything else? And I'm not asking Inge, who just taught you about AGP, but are we picking up any other? Are we picking up an area where the patient is probably going high in the day? So, do you all feel that amongst all of this, there is still a spike here, right? And this is an estimated A1C, so do not give much importance to your estimated A1C. This patient's actual A1C at this point was 7.8. Patient, of course, wants to improve on the control. Which part of the day is responsible? Is it this evening thing? And a lot of people in our culture with the evening snack actually land up with a high pre-dinner sugar. And then, taking the drug at dinner is helping because by that time they've already spiked. So when you actually do the CGM and you identify where they are spiking, you may customize your drug to that event, that time. So which is what we did here, that you continued practically everything same with mild modification in the insulin, but shifted your repaglinide voglibose from from the dinner time to evening 6 p.m. with the snack, and that's what lands up probably helping the patient. Quickly, I'm running out of time, but my last case is on somebody started on steroid, A1C 7.9. Again, metformin, vildagliptin. I am biased towards vildagliptin, isn't it? And patient on glimepiride, metformin, started on steroids. Real-time CGM was advised, and because of the steroid use, and we know the impact of steroids, many here do believe that glyclazide is a better drug when patient is on oral steroids for the kind of pharmacokinetic profile it has as compared to glimepiride. So this is what we saw when the patient is on the steroid with the earlier set of drugs, which was vildamet and glimepiride metformin, and we're clearly looking at the spikes. Right. Well, patients on steroid, you may not be able to completely avoid these spikes. Patients will have some spikes still. But by shifting purely from the glimepiride combination, what we did here was we identified the spikes at breakfast, right? And by identifying the spikes at breakfast, all we did was change the time of the medication. We got the glyclazide metformin was shifted to breakfast. So instead of 010, we went to 100 and shifted the vilda metformin to lunch and dinner. Right? This is something that we wouldn't have thought of doing before the CGM era, because we would have said, where's the evidence? Why are you doing this? Today, again, because of CGM, you're seeing actually what is happening and customizing your drug timing to suit that. And with that, over the next few days, we could see reductions in the post-breakfast spike gradually coming down as compared to what was happening before. So that's my final case for the use of CGM and OHA. So real-time CGMs do enable precise identification of the patterns. Reduction in hypoglycemia and spikes can be achieved by use of CGMs, and enhance patient engagement. CGMs, of course, empower patients to make more informed life choices. Not only the patients, they also empower the physicians to take the right choices. And this leads to improved clinical outcomes. So with that, let me thank all of you and hand it back to the chairs for the discussion.